Let's carry on with our vitamin D story. So important for maintenance of blood calcium and phosphate levels is a hormone. And it's also been purported to have lots of other effects. So adequate vitamin D levels have been associated with decreased incidence of cancer, improved immunity, and improved overall general health. So it's thought that we probably need to supplement our vitamin D, certainly in the winter months. Its therapeutic use is more typically in association with diseases around vitamin D uptake or vitamin D production or vitamin D receptors. So things such as rickets, which is a disease we'll talk about, which is inappropriate or decreased amounts of vitamin D, and therefore you end up with a condition known as osteomalacia, where you don't get sufficient mineralization of bone. You make the matrix, but you don't mineralize it properly. So it's called rickets in children, and it's called osteomalacia. It's the same condition in adults. It's called osteomalacia. Osteoporosis, on the other hand, which is a highly prevalent condition, particularly in older adults, is helped by adequate vitamin D intake and maintaining good vitamin D levels. And then psoriasis, lots of people find that exposure to sunlight and adequate amounts of vitamin D helps improve psoriasis. It's certainly not a cure for psoriasis, but it helps improve psoriasis, and that talks to some of the vitamin D effects on skin. Less well understood are the potential effects of vitamin D in cancer, particularly prostate cancer, where adequate amounts of vitamin D levels are associated with decreased incidence of colorectal and prostate cancer. And then autoimmune diseases may talk to the effects of vitamin D on the immune system, particularly in modulation of T-cell responses. So lots of reasons, once again, to maintain our vitamin D levels. So the RDA for vitamin D is somewhere around 600 IU for adults, whereas most people in the field of bone, and certainly physicians that work with people with bone disorders, typically suggest taking 1,000 international units of vitamin D rather than 600. So we do have the ability to produce vitamin D ourselves, and we can do that from cholesterol. So cholesterol then is acted on by UV interaction with cells on your skin to produce cholecalciferol, which is vitamin D3. And cholecalciferol then can travel to the liver and become 25-hydroxylated to calcidiol, so that's 25-hydroxy cholecalciferol or 25-hydroxy vitamin D3. And then that travels to the kidney, where it's acted on by another CYP enzyme, CYP27B1, where it is then terminally hydroxylated to give you 1,25-dihydroxy vitamin D3. And that is the active form of vitamin D. It's also known as calcitriol. So this form of vitamin D is what can interact with its receptors and regulate bone and regulate calcium absorption from the gut. So you need to have adequate exposure to the UV rays on your skin in order to be able to produce vitamin D yourself. And you also have to have good liver function and good renal function in order for you to go through these appropriate hydroxylations to produce the active form of vitamin D. So what typically do we supplement when we take vitamin D? We typically take vitamin D3, because unless you have problems with your liver and your kidneys, That's a nice cheap form. It's a relatively cheap supplement, and you can take a few hundred or even 1,000 units of vitamin D, and then it will be appropriately metabolized in your body. So vitamin D interacts with a vitamin D receptor, which is a nuclear receptor. So calcitriol forms a complex with vitamin D, so that's the 1,25-hydroxyvitamin D, binds to the vitamin D receptor in the nucleus, and then that combines with the RXR to form a heterodimer, and together then those bind to the vitamin D response elements. So you find the vitamin D response elements on genes that are responsible for increasing calcium uptake across the gut, so the uptake of calcium and transportation across the cell and then release into the bloodstream, as well as in cells in the bone to regulate mineralization. So in particular the osteoblastic cells, which produce the matrix and mineralize the matrix. And that mineralization is under control of vitamin D. So you see changes in loss of gene transcription in response to vitamin D. So bone-related genes, including this one here, which is another CYP enzyme, the 24-hydroxylase, that is responsible for inactivation of vitamin D. So vitamin D the active form will stimulate the enzyme that will inactivate vitamin D, as well as things such as TGF-beta and P21, which are important for osteoblast activity. So vitamin D toxicity can occur if you do take mega amounts of it. So it doesn't occur if you bake yourself in the sun for long periods of time. So not too many people do that anymore, but if you do have large amounts of exposure to the sun, then if you do not have highly pigmented skin, so the more pigmented your skin is naturally, the less vitamin D that you will produce from the actions of the sun. So if your skin is more pigmented, you will need longer sun exposure, or you would need more supplementation with vitamin D. So the whiter your skin, the more easy it is for your skin to produce vitamin D, or the vitamin D precursor. But people who supplement, if you do have very high doses of supplementation, then you can end up with vitamin D toxicity. And as is very typical with vitamins, when you get toxicity, you get the opposite effect of what the vitamin normally does. So what do you see when you see vitamin D toxicity? You see demineralization of the bones as opposed to mineralization of the bones. So it can be a problem. Adverse effects are mainly due to elevated blood calcium levels. So if they're excessively high, you can get fatigue, headache, diarrhea, and those will come about as a result of hypercalcemia, having too much extracellular calcium. And there's that demineralization that can occur as a result of the toxicity, but there's lots of other things that can happen. Potential increased calcification of other organs, which is not something we'd like to see, and effects on growth arrest of lots of different cell types. So you do see wide expression of vitamin D receptors even outside of the gut and the bone. Okay, so vitamin D deficiency is quite prevalent for those of us who live in the extreme north, but when we live in the north or we live in the south, so away from the equatorial regions. And that is because we have exposure to sunlight, but the amount of UV radiation in that sunlight is not sufficient to produce vitamin D for various periods of time. So at latitude 42 degrees north, so around the area of Boston, for example, in the United States, between November and February, so this would also apply to Northern Europe, between the months of November and February, then you cannot produce enough vitamin D from the exposure to sunlight. Even if you were to stand out there on a sunny ski hill, stark naked, you wouldn't produce enough vitamin D. So no need to rip your clothes off when you go skiing next time, okay? So you will get a bit of a suntan eventually, right? But it won't be sufficient. Now, as we start to go further north, so when we get to even Edmonton, for example, that extends to the months from October to March. And as you keep going further north, it gets worse and worse and worse. So when you end up in the Northwest Territories or Yukon, for example, or if you're in northern Finland, then you don't get a lot of exposure. So first of all, you have very long days, night times in the winter time, and you don't get enough exposure for very prolonged periods of time. Probably a good 8 out of 12 months of the year, you would not get enough exposure. Okay, so that means then that you need to have some sort of vitamin D sufficiency. So here's an example of a study of the Canadian population. So this is our regular off-the-street Canadian population. And so you would probably fit into this. And so if we look at the vitamin D levels in that population, taking a conservative amount of vitamin D, so adequate vitamin D of 40 nanomoles per liter of 25 hydroxy vitamin D. So that's typically what you measure. If you go to your doctor and they measure your vitamin D, they don't measure your 125, which is the active form. They measure your 25 hydroxy D. It's not active, but it is more stable. The level of that is more stable. So that's why they measure 25 hydroxy D. And so if you take a conservative estimate of about 40 nanomoles per liter, you will find that people, various amounts of people are going to be deficient, considered to be deficient at various times in the year. And you can see that those deficiency levels go down in the summertime because we do have enough exposure to sunlight, or sunlight with enough UV rays. Whereas in the winters, in the fall it starts to climb, and in the winter it goes up even higher. And you can find that in total then, about 35% of the population then could be considered to be inadequate, have inadequate amounts of vitamin D by these levels. Now, as we start to go higher, so some people think that the adequate amount of vitamin D is one where you get no stimulation of the parathyroids. And that won't make an awful lot of sense to you right now, but it will when we've got through our parathyroid lecture. But basically, vitamin D can regulate parathyroid hormone secretion if you have inadequate amounts of vitamin D. So in order to shut off that parathyroid hormone secretion, you need somewhere in the order of 80 nanomoles per liter. So when you get up to that level, which is shown in green here, you can see that the majority of the population are considered to be vitamin D deficient by those criteria pretty much the whole time throughout the year, with a little bit of a dip in the summertime. So overall, most people will be considered to be vitamin D deficient by those criteria. Your doctor is going to be looking at this level, around 40 nanomoles per liter. So most people then, some people will be deficient by those criteria and some not, right? Depends when you have your blood drawn. So that says that we probably do need to supplement. There are two other things you need to keep in mind. People use a lot of sunscreens, in order to decrease the effects, the deleterious effects of UV light on our skin, to decrease skin cancer, right? And with the increase in those sunblocks, there is decreased amount of vitamin D production. So you don't need to be exposed to sun for prolonged periods of time. In the middle of the summertime, you go outside, and exposure of your arms, face, your hands, probably your legs if you're wearing shorts or skirt, is sufficient for about 15 minutes, is sufficient to give you an adequate amount of vitamin D. So you don't have to be laying in the sun for hours on end and baking in order to get your vitamin D, okay? So you would normally get that just by walking around in the summertime, right? But if you're somebody who applies sunscreens, heavy-duty sunscreens, all the time, So if you get up in the morning and cover yourself with a factor 50 sunscreen, you're not going to get adequate amount of vitamin D even in the summertime. The other case is when you have highly pigmented skin. So if you're of African American or African origin, and so you have highly pigmented skin, then you will also have to have larger amounts of sun exposure in order for you to get that vitamin D. And thirdly is situation that comes for Muslim women, for example, who cover a lot of their body, sometimes almost all of their body when they go outside. And so that often creates a problem for them to get sufficient amounts of vitamin D. Again, it's a good idea if they can find time and appropriate place for them to go and get, about 15 minutes of sun exposure on a little larger area of their body at some time during the day, or take more vitamin D supplements. So there is a fair amount of vitamin D insufficiency, even in highly, more equatorial countries that get lots and lots of sunlight exposure, particularly for populations in the Middle East, for example, where people tend to cover themselves more, particularly for women. So those are the three sort of situations where you see some problems. Now, what happens when you have vitamin D deficiency? So if you're an infant, if you're a young person, what you typically see is rachitic bone. And that's because the bone hasn't mineralized properly. And as a result of that, the effect of gravity on this young boy's legs then is caused bowing of the legs. So those bowed legs are what are considered to be sort of signature, the hallmark of rickets. And these rickets is a highly prevalent condition in northern populations before we started to add supplementation to lots of our foods. So our dairy products are supplemented, at least our milk is supplemented with vitamin D. Yogurt has increased vitamin D in it. Cheese, aged cheese particularly, does not. But even for people who don't take in dairy products for whatever reason, they don't want to take them in or they can't, you can get supplemented juices, supplemented soy milk, nut milks, all those things these days. So lots of ways in which you can take it in. So rickets may be a result of vitamin D insufficient or mutations in the vitamin D receptor. Mutations in the vitamin D receptor, of course, are then a big problem to treat, because giving more and more vitamin D isn't going to fix that problem. But if it's just insufficiency, we can get around that. So osteomalacia in adults, so if you become vitamin D insufficient, it's characterized by decreased, it's got cut off here, it should be bone mineral content, and you would also see typically bone pain, you present with bone pain, and soft bones and potential for osteoporosis as an adult. So thinking about what our vitamin D is doing then, so in response to low serum calcium levels, parathyroid glands release parathyroid hormone. And that parathyroid hormone is what stimulates that CYP27B1 in the kidney, the enzyme that's going to produce that 1,25-dihydroxy vitamin D. So that's where the PTH comes in. And then the vitamin D will feed back to those parathyroids and decrease the amount of PTH which is being secreted. So that's where that increased level that I was talking about to shut down PTH comes in. So your calcitriol, then you've taken up your vitamin D, liver has produced a 25-hydroxy-D, now in your kidney, under the control of your PTH, will stimulate and produce 1,25-dihydroxy-D. And that'll go to your intestines and increase the amount of calcium absorption from your gut. So taking in lots of calcium, you will get lots of passive absorption of calcium, but to improve that So particularly if you are not taking in large amounts of calcium in your diet, vitamin D is absolutely vital. If you're taking in lots and lots of calcium, so if you drink tons of milk and eat lots of cheese and yogurt and things, for example, and you're taking in 2 grams of calcium a day, for example, then your vitamin D will not be as important. It's when you're down at the lower end, and most of us don't take in 2 grams of calcium a day. When we're down at the lower end and we're only taking in, a few hundred milligrams of calcium a day, that's when your vitamin D is really important and will stimulate the amount of calcium you can take up from the gut. And then vitamin D also acts on the bones then, and it will help to mineralize those bones, and it will also help to mobilize calcium from the bones if necessary. So, when do we need to worry about our vitamin D? So decreased serum levels of calcitriol with some drugs. So if you're taking phenytoin, so you've probably heard about phenytoin and PCL201, right? Sort of classic pharmacokinetic drug, right? So if you're taking phenytoin, what's phenytoin used for? Yeah, for seizures, right? So if you're taking phenytoin, then there will be decreased amounts of calcitriol. Or if you're taking phenobarbital. Decreased intestinal absorption of vitamin D, again seen when people are taking drugs that alter the amount of fat absorption. If you're taking in lots of mineral oil, so remember back in PCL302 we talked about some drugs, those used for constipation, right, which was all about increasing the gut and then, lubricating the content of the gut. Mineral oil was one of the drugs that you can use for constipation, and if you do that, that increased amount of oil, which is going to stay in the gut, is also going to be dissolving your fat-soluble vitamins, and so they will tend to be increased excretion. And then this olestra is that synthetic fat that I talked about. So the olestra sort of came on the market quite a long time ago now, probably at least 20 years ago, long before your time. It came along as one of those things, you can eat lots of fat and it won't get absorbed, so no problem, right? You can eat lots of it and you'll just poop it out. Of course, the trouble with that is that you end up with a lot of fat in your feces, which is not particularly pleasant and causes problems at the lower end, should we say. All right, so olestra then the shine went off that very quickly, and I don't think that you'll find olestra around very much anymore. But at one time it was being marketed as the new margarine to be used, yeah? Blockade of the vitamin D receptor activation by glucocorticoids. And glucocorticoids have lots of effects on bone. They dramatically decrease bone density. Part of that effect is from blocking the effects of vitamin D, and part of it is for other regulation that they have at the level of bone. All right, so hypocalcemia, just to give you a little bit of background on this, so less than 2.05 millimolar total calcium, and about 50% of the total calcium that's circulating in your blood is ionized and can be used and taken up by yourself, and 50% of it is not ionized and is not useful, but that's at equilibrium. But we measure oftentimes total calcium. So if you've got less than 2.05 millimolar, then you're considered to be hypocalcemic, have decreased amount of calcium, and you end up with, strangely enough, neuromuscular irritability. So you expect it to be the opposite. You expect if you have lots of calcium around and you have lots of stimulation of calcium-sensitive pathways, that you would have the irritability, but it's not. It's when you have the hypocalcemia. So you end up with all sorts of problems, numbness and tingling in the feet, muscle cramps. You can even get to the level of tetany and convulsions, spasms and bronchial spasms and laryngospasms. irritability and impaired mental capacity and personality changes. So I come from a sort of calcium endocrine background, and my doctoral mentor was giving evidence in a trial of a woman who was accused of attacking one of her family members, and she was pleading mental instability or mental incapacity as a result of as a result of hypocalcemia. So he was giving evidence in a trial to support that, and indeed it has very profound effects on your personality and your behavior. So if you notice unusual behavior in your family member, you might want to give them an ice cream to eat and help improve their calcium intake or something like that. I'm sorry, I'm being facetious, but you can see those changes under extreme conditions. So lots of causes: hypoparathyroidism, parathyroid hormone resistance, vitamin D deficiency, and vitamin D resistance in some cases with changes in vitamin D receptors, and some drug-induced effects. So, hypocalcemia, but how do you treat it? If it's fairly mild and asymptomatic, then you would typically just give some calcium supplements and some vitamin D supplements to the person. So oral calcium and vitamin D supplements would be the way to go. 1 to 2 grams of calcium a day, and they can be either calcium carbonate, calcium gluconate, calcium citrate. There's lots of different types. Calcium citrate is slightly better absorbed than gluconate and carbonate, but pretty much any source of calcium will do. If it's moderate to severe, then this has to be treated with intravenous calcium, and for that we use calcium gluconate, which is the preferred source, rather than bring along lots of chloride with calcium chloride. And it has to be administered intravenously. You don't want any of this to be subcutaneous. It's very painful if you get calcium under the skin. And it has to be administered very slowly. If you administer a bolus of calcium, you'll put the person into cardiac arrest. So it has to be administered very slowly and intravenously. But that's only under extreme conditions. So vitamin D therapy, then you can, typically what most of us will take will be vitamin D3 or vitamin D2, ergocalciferol, which is just a plant form of vitamin D. It works just as well, there's no problem with that. So vitamin D2, vitamin D3. Under some conditions, ergocalciferol, which is your 25-hydroxy-D, may be needed to be, if you need to increase the vitamin D more rapidly, or even 1,25-dihydroxy-D calcitriol, most expensive form, if you really need to get that vitamin D level up quickly. Considerations for therapy: time to reach equilibrium. Again, fat soluble, there's going to be a pool in the fat, so time to reach equilibrium is going to take a few months, typically. And if you need to withdraw, equally, it'll take a few months before you deplete those stores. Oral absorption is fine as long as you don't have fat malabsorption and your kidneys and livers are in good shape. Drug interactions: some anticonvulsants inhibit hydroxylation in the liver, and so that can be a problem. And your glucocorticoids cause problems with vitamin D and vitamin D responses. So hypocalcemia, on the other hand, is when you're in the normal range of 2.1 to 2.5. So if you're above 2.5, then you're considered to be hypercalcemic. You don't normally see symptoms until you get up to about 2.9 nanomolar. Sorry, millimolar, not nanomolar. And what do you see when you are hypercalcemic? Lack of concentration, increased sleep and lethargy, so the opposite. So you're not getting that neuromuscular irritability, you're getting the opposite. Headache, muscle weakness, vomiting, diarrhea, changes in renal function, and even coma. So it is something you needs to be treated. Most common primary hyperparathyroidism or secondary hyperparathyroidism can cause increased amounts of calcium. Ectopic vitamin D production, if you get vitamin D which is being produced unregulated, there are a number of other places in the body where you have the 1-hydroxylase enzyme expressed, including in the skin and in kidney and in bone itself. You can end up with excess amounts of vitamin D from that ectopic expression. Lytic bone metastases. So these are metastases from cancers where lytic means it's breaking down the bone. Very common as a metastases from prostate cancer and breast cancer. They're the two most common cancers. And they are very often metabolized to bone, causing lytic lesions, which are extremely painful. So that's going to cause a lot of breakdown of bone and as a result, a lot of release of calcium. Less common thyroid toxicosis, so excessive amounts of thyroid hormone, sarcoidosis, which is another type of cancer where you get lots of 1-hydroxylase being produced and therefore producing lots of vitamin D. Immobilization, so if you're immobile for prolonged periods of time with bed rest, or if you're an astronaut, which typically most of them are not astronauts, but if you're immobilized for prolonged periods of time with prolonged bed rest, this could be a problem. And that's because your bones start to resorb as you're immobilized, because bones are optimal when they are stressed by gravity and movement. And so if you're not moving very much, you'll start to resorb your bone. And some drug-induced. There is an error here. So this says diuretics, and that's incorrect. So loop diuretics will cause hypocalcemia, not hypercalcemia. But lithium, estrogens, and androgens can all cause hypercalcemia. Treatment depends on the level. Very typically, you want to look for the underlying problem. But if you have mild hypercalcemia, then it's asymptomatic. You need to just treat the underlying problem, if possible. If it's more aggressive, though, more aggressively treated, the higher the levels of calcium. Otherwise, you might end up in a calcium-induced coma. So hydration and loop diuretics. So IV, loop diuretics, flushing out lots of calcium. Remember that one of the problems with our loop diuretics is they interfered with calcium reabsorption in the loop ependym. Mobilization, if you are immobile. Bisphosphonates, if you want to decrease the amount of bone resorption. Calcitonin, if you want to decrease. Plicamycin, these all decrease the amount of bone resorption. Glucocorticoids, if you have something like sarcoidosis, for example, where you'd like to control that with glucocorticoids. All right, so we have a little case study here. So before I go through this, do you have any questions? I've been rattling on about things.
Yeah. So when you have a diet that's really high in fat, will that decrease the absorption of fat-soluble vitamins because they just pass through, or will it increase it?
Well, if they're not fats that can normally be absorbed,
Okay.
then not too much. I mean, when you say really high in fat, like when you're talking about
like a ketogenic diet.
Ketogenic diet, yeah. So if you're on a ketogenic diet, which seems to be the rage these days for weight loss, and it's also used for treatment of intractable epilepsy too, right? Then it is a good idea to increase the amount of vitamins, fat-soluble vitamins that you're taking in to try and compensate for that. Because you will excrete more fat if you've got a high-fat diet. But for most people, unless you're truly trying to, eat very high-fat diet, that's not too much of an issue. I can tell you from treating mice, because I do a lot of work on bones and that in mice, and also lots of other things in terms of their mental capacity. when we treat mice with high-fat diets. So something like a 60% fat diet, which is very high, probably similar to the levels of what you'd see in a ketogenic diet. They get extremely fat. Extremely fat. So it's certainly in a mouse, is not, ketogenic diet is not the route to weight loss. But it probably works, I think, as a route to weight loss. I think it works better in males than it does in females. I don't know if there's any information about that, but seems to work better in males and females. Okay, so KR is a 65-year-old African-American male who lives in Seattle. Seattle, which is well known for its dreary, wet weather, much like Vancouver, right? And works the night shift, so he usually sleeps from 7 till 7 a.m. when he gets off of work to 6 p.m. He's not been feeling very good recently, and he presents at his community clinic with a variety of symptoms. He's got spasms in his hands and his feet, difficulty walking upstairs and fatigue, suggesting that he's got some muscle fatigue problems. And upon clinical interview, he complains of lower back and hip pain. And his history reveals that he is also lactose intolerant. So he tends not to consume dairy products. Upon physical exam, the physician notes an irregular heartbeat and lordosis. So lordosis is swayed back. And blood and urine panels are ordered, as well as a low back hip x-ray. So his blood and urine work reveals that he has low serum calcium and phosphate and decreased urine calcium. His x-ray reveals that he has pseudofractures in his spine, hence the lower back pain. And he has a low bone mineral density in the hip, with softening of those bones being apparent. So decreased mineral content. Diagnosis, osteomalacia with vitamin D deficiency and secondary calcium deficiency. So he is being treated with vitamin D, calcium and calcium supplements for 4 to 6 weeks to see how he gets along with this. So let's think about what it is that has been measured. So we've looked at his blood and his urine. So we see decreased amounts of calcium and phosphate in his blood. We're looking at his urine as well. Why are we looking at his urine? I mean, do we care about his urine? Why do we care about it?
Maybe he has enough levels, but if it's increased in the urine, that means he's excreting it.
Right, so it would help us rule out if there's something different about because of increased excretion, right? So if he had high levels of calcium in his urine and low levels of calcium in his blood, which it shouldn't be, right? If it's low in the blood, it should be low in the urine because your body should be trying to conserve it, right? It may indicate that he had a problem with his parathyroid glands. If he's getting excessive, he had secondary hyperparathyroidism or even primary hyperparathyroidism, he'd be stimulating his calcium excretion potentially inappropriately. Okay, so we've looked at that, and that looks as if that's not an issue. These things are going in the same direction. So serum calcium and phosphate is not where it needs to be. So what does that suggest? Why has he got decreased amounts of calcium? Yeah.
Is that the combination of his inability to consume dairy products and the vitamin D deficiency?
Right, and why is he vitamin D deficient?
Because of his sleeping schedule as well as his skin pigmentation.
Right.
And I believe, that's just what I can think of.
Right. Yeah, so he's sleeping during the daytime, so even in dreary also Seattle, he's not getting exposure to much sunlight, right? And so that's a problem. And if he hasn't supplemented with vitamin D, which presumably he hasn't, and he's not taking in dairy, and so in North America, dairy would be one of his big sources of vitamin D as well. So if he's not taking in that, and if he's not taking in some of the newer supplemented non-dairy sources of calcium, then that would also be a problem, right? So he's probably got a poor diet, not taking care of his calcium intake, not taking care of his vitamin D levels, and as a result of that, then he's ended up with osteomalacia. So these pseudo-fractures that he has in his spine, typically what you would see then is not a complete fracture, which would be absolutely agonizing, but you see collapse of the spine, the vertebrae. You start to see some collapse, and that's because of demineralization of the bone in those vertebrae. And so that's going to give a lot of lower back pain. And that is very typically what you see with a presentation of decreased vitamin D in people, even those who are taking on board calcium. Okay, so let's have a look at our questions. So what factors contributed to his vitamin D deficiency? So you've already answered that for us. So it's his shift working, insufficient exposure to sunlight, and insufficient intake. Why did he feel unwell? So that goes back to his hypocalcemia, right? So if you look at those hypocalcemic effects, and he's not feeling well, he doesn't have good muscle function. He may even be feeling nauseous at times. So he's not feeling well because of his hypocalcemia. What would you expect his 25-hydroxy D level to be looking like? Would you expect it to be high? Expect it to be low? Expect it to be normal? What do you expect?
Lower than the, I think it was 40
Yeah.
milligrams.
Yeah. So you would expect him to have pretty low levels of vitamin D. If he's been going through this pattern for long periods of time, he's slowly depleting his 25-hydroxy D stores. And so you would expect even his 25-hydroxy D levels to be quite low. Now you can also see 25-hydroxy D levels in more acute environments. 25-hydroxy D levels that are low, but sufficient amounts of 125-hydroxy D. Because even with lower, 25-hydroxy D is present in about 1,000-fold excess over 125-hydroxy D. So you have lots of 25-hydroxy D that's circulating, and so you can have adequate amounts of 125-hydroxy D even with quite low levels of 25-hydroxy D. So sometimes 25-hydroxy D levels may be very low, but 125 could be enough. That's typically in a more acute environment, but with the long term, you will deplete both. You will deplete both 25 and 125-hydroxy D. So the fact that he's got osteomalacia suggests his 125 levels would also be low if we were to look at them. So what type of vitamin D would we use to most rapidly ameliorate the symptoms? So if you were the doctor writing out that prescription, now he's living in the States, so you do have to be mindful of his costs. What would you be giving him? Yeah, so you could be giving the 125, but if this person doesn't have a drug plan, for example, 125 plus trial is actually pretty expensive. And so you may want to give him, say, 25-hydroxy D. It'll work faster than just giving him plain old vitamin D3, but will not be quite as expensive. So you might want to hit that mid-range. So remember that you always have to take into account people's socioeconomic factors in addition to their health factors. If he's got a drug plan that would support that, then you could give him calcitriol, and that would act most rapidly. But then you do need to keep track of that and make sure you don't make him end up with excessive amounts of vitamin D. So this is not that unusual a presentation. So you don't necessarily have to be a ship worker to end up in this situation. So just keep that in mind. Okay, lower back pain, sometimes if it's not as a result of injury, is probably your first indication that you might have some bone problems. But it's also a first indication that you might have some disc problems, but if that's not, if you don't have a history of disc problems, it might be an indication of bone problems. All right, guys, I'll see you next week. And I will put up your endocrine lecture notes. Regulation.